Welcome, everybody. My name is Louisa Sylvia. I'm the director for the Office of Women's Careers at Mass General, and it's my pleasure to introduce our 8th Anne Klibanski Visiting Lecture Series today on clinical and educational programs for the underserved on maintaining brain health with Dr. Joo and Dr. Chemali. First, I'm just going to give a little bit of an introduction, and then we'll have our speakers give their talk. So first, for those of you who are not familiar with the Anne Klibanski Visiting Scholar Award, it was developed this past year during COVID-19. As COVID, many of you likely know, disproportionately affects women with additional childcare and household responsibilities and ailing relatives. It really became obvious in the past year that women were having more difficulty with visiting professorships because of these challenges, getting talks, grand round talks, and really kind of networking, collaborating with others. So for that reason, the Center for Faculty Development established this award with Dr. Chemali as one of those awardees. And so we're thrilled to have her here with one of our partnering organizations, Johns Hopkins with Dr. Joo, as a way to highlight the work that she's been doing and to essentially give a virtual visiting professor lecture. So first, those of you who may not know Anne Klibanski, she's the president and CEO of MGB and the former director of the Center for Faculty Development. So it's a real honor to name this after her and the work that she's done, both as a researcher and a clinician in the neuroendocrine unit, as well as her leadership roles in the Harvard Catalyst Endocrine Society. And she's obviously been extremely successful as a clinical researcher. And again, so we're thrilled to have her support in this award named after her. And these are all of our scholars from this past year. And that lovely red box highlights Dr. Chemali, who will be speaking shortly as our Anne Klibanski Scholar Awardee. And then, as I already mentioned, Dr. Joo is from Johns Hopkins. She's one of our partnering organizations who was so excited to do these visiting lecture series. They said, let's do the talks together where we can have both our partnering organizations who supporting our scholars with our scholars to give a talk, which is wonderful. And this has really started this visiting lecture series. And again, this was to support the advancement of careers of women at Mass General. And we really want to bring, again, faculty members from across institutions to give these talks together and to network and collaborate with one another. That was really one of the main goals of this lecture series. And I hope that this will start a collaboration for years to come across these two organizations, which is great. So without further ado, let me introduce our speakers. Dr. Joo will be going first, giving a talk on innovative clinical educational programs and health services for maintaining brain health. She's associate professor in the School of Medicine at the Division of Geriatric Psychiatry and Neuropsychiatry at Johns Hopkins and has a joint appointment in the Bloomberg School of Public Health and the Department of Mental Health. And her research includes health services on depression and dementia for underserved older adults. And Dr. Chemali will go next. She'll be giving a talk on clinical and educational brain health programs locally, nationally, and worldwide. She's an associate professor in psychiatry and neurology at Mass General and Harvard Medical School, as well as the director of the neuropsychiatric clinics and training in the Department of Psychiatry and Neurology. And her clinical interests and expertise are around the practice of neuropsychiatry, behavioral neurology, and brain health with a special interest in early onset dementia. So with that, I will pass it over to Dr. Joo. Thank you so much for being here today.
All right, thank you so much. I'm gonna share my screen. All right. So I'm really excited to be a part of this series. I think it's great to bring women faculty together, to share our knowledge and our work. So thank you very much. So what I wanted to speak today to everyone about was my work on using paraprofessionals in depression care delivery among older adults. So I'd like to briefly just describe the problem and set the conceptual frame. So it's not a common thing to think about how paraprofessionals could be involved in healthcare, especially in healthcare systems where the knowledge is very deep, the specialty knowledge is very deep. And sometimes customary ideas of thinking about treatment and depression care don't necessarily support use of paraprofessionals. So I wanted to also introduce some ideas in which ways in which I'm kind of rethinking some things. And then I'd like to go on to describe the implementation of a trial that I'm conducting, a randomized controlled trial, which is testing a psychosocial intervention. So everyone understands that depression is a public health issue. Among older adults, prevalence is about 5% in the community, but it can be as high as up to 30% or more in institutionalized settings. Despite the fact that we have evidence-based interventions, the majority don't receive depression treatment. And for various reasons related to the patient themselves, perhaps the family, stigma and help-seeking behaviors, identification is low and they're undertreated. If they're lucky to get treatment, though, it's also true that there is poor adherence to antidepressants, and they may drop out prematurely from psychotherapy. And Dr. Bartels, who's at MGH, in a study on PRISM, showed that even if patients are given money to go to their first appointment and provided transportation, they still have a lot of difficulty in following up with referrals to specialty care. And we know that the mental health workforce is inadequate to meet all needs. So I started thinking about the various types of barriers that exist. And one way of thinking about it from a very eagle's eye point of view is thinking about the community and the health system as cultures. And could the two different types of cultures lead to differences in access and outcomes. So both cultures, the health system and the community, affect the health of the patient. Health system provides preventive care and acute care, but there's also healthcare that's taking place in the community. So the community is where self-management occurs. And there are also social network influences that have an impact on how people seek care and whether they seek care. So persons go back and forth from the community to the health system. There may be some people, though, who have more difficulty making that transition. They may have difficulty with concepts, with the language of healthcare, with the organization of healthcare that makes navigation difficult, and that also makes physician-patient communication difficult. And those factors could lead to differences in access and outcomes. So that's where the idea of using paraprofessionals who may be able to ease that transition could be very helpful. So I know in healthcare, we don't necessarily think about tailoring treatments. When we think about antidepressants and psychotherapy, they're treatments that typically we don't think need to be modified or are not modified for particular patients. But when we think about healthcare delivery, though, it could be that those types of treatments need to be tailored so that people have equal access, meaning that it's acceptable to them. It doesn't stigmatize them so much that they refuse to take them or engage in care. So as I think about my work and how to develop a model of care in which paraprofessionals are used to engage older adults, I think about depression as a chronic illness with symptoms that wax and wane. And we all know, of course, we focus on the patient as the individual and the psychology of the individual and the decisions they make to get care or not. But I also think about the social factors, the family that has an impact on whether they get care or not, whether they adhere to medications, whether they decide to seek help, and the importance of the relationship, whether it's in their social network or whether it's with a physician or even the paraprofessional, and how important that is in terms of getting into care and managing depression. So people go from the community to the health system and back and forth. And in the community, as I mentioned, they're also thinking about taking care of themselves. And so integrating self-care, teaching them about self-management for depression to complement the care that they get from professionals in between their doctor's visits or in between, if they have to go into the hospital. And communities have lots of resources. So they may not be medical resources, but they may be resources that can be brought to bear on managing depression in the community. And so using that also. So to come a bit down from the abstract, the people that I work with and I hope to have an impact with the study that I'm conducting are low-income and ethnic minority older adults. They're typically, they don't have a great deal of resources. Being older adults, they may be socially isolated. There may be a great deal of stigma regarding mental health and whether mental health is something that you seek help for in the medical sector. They often have multiple medical conditions, and they typically do not seek specialty care. The majority of them get depression and mental health care in their primary care setting. So this is the population that I work with. So the study is called Peers, and I just wanted to start with a definition of how I'm defining them. So the peer mentors are lay health workers, and they're trained and supervised. They're in the particular study, they're older adults, and they have history of depression. So a diagnosis, and they've been in treatment. The majority have had psychotherapy. They've been on medications. They aren't patients, so they're workers, and so they're fully functional and able to do the job and fully. So what they do in terms of their role is they provide social support and self-care knowledge to decrease depressive symptoms among older adults. And they link the older adults to community and clinical resources. So there's a long tradition of lay health support, many names for them as well. Community health workers are probably the most common name. Peer mentors, I would say, are kind of like the mental health counterpart. They're used in diverse settings, nationally, internationally, and there's strong policy support through SAMHSA, as well as research funding. And in terms of, I call them peer mentors, but peer specialists are a recognized workforce. And depending on what state you are, in Maryland, there's an infrastructure for training and supervision, although currently they're not reimbursed, but some states do reimburse for their services for Medicaid patients. So in terms of research, there have been meta-analyses that have shown benefit for specifically depression, although the quality of the evidence is moderate. And there are no studies that have been done specifically among older adults. And so that's what I'm seeking to do. So this is a schematic of the model that I'm testing in my study. So the core of the intervention is the peer mentor, who is the interventionist. It's a community-based intervention, which makes it convenient. So clinics are of course, very convenient for healthcare providers, but they're not always convenient for older adults who may be underserved and who may have difficulty with transportation and making it to primary care clinics or specialty clinics on a regular basis. In the interaction, what occurs is strong relationship building and social support. There's a lot of social learning. So the peer mentor who has experiential knowledge provides modeling, shares information, and a lot of peer support interventions or peer delivered interventions sometimes have difficulty with defining their role. And so I made very careful attention to defining role and encouraging the peer mentor, encouraging behavior change with the older adult so that there's some degree of goal setting and a linkage to resources. So this is a trial, it's a single blind trial with an active control. The peer intervention is 8 weeks, and we'll be doing follow up to 12 months, 3, 6, 9, and 12. And the outcome is depression as measured by the PHQ-9, but we're also measuring secondary outcomes as well. So a little bit about the process. So the peer mentors are trained and they're supervised. So they work very, very closely with a clinical social worker who provides weekly supervision. The patients, the older adults, are screened. They're clinically evaluated to make sure that they're appropriate for a peer mentor intervention. For example, suicidality, severe psychiatric symptoms would be an exclusionary factor. Once they're deemed to be eligible, then they're matched and they have 8 weekly calls. So before the pandemic, the plan was to have in-person visits, but because of the pandemic, all visits were transitioned to the telephone. All visits are also audio recorded for quality assurance and also to assess fidelity to the intervention. So there are various types of assessments that we do. So the baseline assessments, post-study, and then the follow-up assessments. We're also doing weekly assessments because we will be doing a mediation analysis to have an understanding of what's actually changing that's causing, hopefully, the intervention to be successful. In addition to the quantitative assessments, we're also doing qualitative assessments as well. So for the participants who are in the intervention condition, we're doing semi-structured interviews with them to assess their experience and to get their insights about what's changing and what's working, or what may not be working as well. And then we'll also be gathering some implementation data, data to assess barriers and facilitators of the intervention. So, of course, we were affected by the pandemic, as everybody was, in the research setting. And we started enrolling last year in February, and about a month into it, our recruitment had to be suspended. And I just present here a study about the impact of the pandemic on mental health, because I think that this also had an impact on the need that we saw actually among older adults as we were conducting outreach to community organizations. So in this study that was published in JAMA, what they found was a 3-fold increase in depression, especially for those who already had depression and suffering some symptoms prior to COVID. And the greatest, not surprisingly, were those who were vulnerable, were fewer resources, low income, less education. And what we've seen in our study, our older adults during the screening process, during the baseline assessments, and of course during the intervention, telling us how the pandemic had negatively affected their mental health. Some who had depression and the pandemic had worsened it, but then there were others who had not had depression and who were feeling not doing emotionally well. So we used an implementation framework called the Seifer to organize some of our impressions thus far. So in terms of the older adults, the idea of peer mentoring or peer support or informal support from somebody their age, somebody who has experience with depression, was very positive. They may have not been very familiar with the idea, but once we described to them what a peer mentor was, they were very accepting. It also resonated in the community with community organizations as well as primary care settings. So again, the idea of an informal support, the idea of a strong relationship with somebody who could provide support as well as self-care knowledge was very positively accepted, received. And in terms of peer support and the infrastructure for recruiting people who could act as peer mentors, in Maryland and Baltimore specifically, there was a strong infrastructure that enabled us to recruit very easily. And we found pretty experienced people who had been volunteering in mental health through organizations like NAMI, or were seeking peer specialist certification and had experience that way. In terms of older adult participants, so the majority are women. Thus far, we're about 2 years into the study, and that's not uncommon in depression studies. The majority, given the demographics in Baltimore, are minority African American older adults, and majority community dwelling and independent. So what we're seeing is a range of depressive symptoms from mild to moderately severe. So the idea, of course, was that we didn't want to recruit or older adults with severe depression, because assuming that they would need, of course, more intensive care and professional support. But what we found was that there are older adults who are experiencing either moderately severe or severe symptoms, who are not getting any care, and who are frankly not interested in being referred. And so we changed the process of the study to include these older adults as well. So at least within the study, they could be monitored, they could be offered referral in connection to professional care if at any point they decided that they wanted to. And then what we're finding too is that this study and the peer mentors working in collaboration with the social worker can facilitate entree into formal care. And whereas it's very difficult to navigate the health system, navigate mental health services and know who to call and where to go, or even to be kind of gentle persuasion about decreasing the stigma around it, that the peer mentor may be useful in doing that. So another very interesting thing that we found, we often look to referrals from professionals who have depression, but we found that direct outreach to older adults was most effective in terms of actually engaging in the study, and that self-identification may suggest readiness to commit, whereas referral obviously suggests that somebody is worried about you, but it doesn't really suggest that you may actually want to be part of the study. So of course there were challenges. So distrust, so that's a very kind of a broad term, but what we're finding with older adults, they're a vulnerable group. They may have been victims of some predatory behavior, and we had some older adults who had experienced that and were very, not very, but justifiably cautious. There were communication difficulties in terms of telephone. So this is a population that is not using text and smartphones and receiving communications at all times of the day. And so being able to reach them was at times challenging. And the reliance on the phone. So as I mentioned, initially we planned for in-person visits. However, we had to switch to telephone, and hard to know for certain, although because our recruitment has been robust, but the idea that perhaps trust is compromised, or maybe perhaps a bit more difficult to establish by telephone rather than in person. So that's something we're considering. So thus far, we have a ways to go yet in terms of finishing and completing the study, but collaboration with community organizations has been very robust. As I mentioned, they're very accepting of the idea of informal support through peer support for depression for their clients. And the idea of potentially starting depression care in the community, starting with self-care support through by the use of peer support, it may be feasible. It's so far we found acceptable. And it's possible to perhaps think about peer support as the first step in a stepped care approach. So older adults who have depressive symptoms which require professional care initially may enter through peer support, but then may be stepped up to professional care if the depressive symptoms aren't alleviated. And we are also thinking about technology. So it's challenging to think about older adults and technology, but there may be a group among the broader older adult population. And so we're thinking about integrating video chats and supportive texting in the simplest way possible, and trying to figure out the type of education and support they would need in order to do that. Because I think everyone recognizes the convenience. Definitely older adults do recognize the convenience as well. And so capitalizing on that and using and integrating manageable technological components might be very, very useful. So thank you very much for your attention.
Hello, everyone. I guess I'm going to take it from here and also share my screen. and I hope that everyone is hearing me. And I thank you very much for giving me the opportunity to get back to this talk and actually share with another a colleague from Johns Hopkins this space, and just to discuss with you kind of on that same note, because I also my main area of interest are vulnerable population, and definitely elders, as you would know, and elderly people are part of this very vulnerable population, and sometimes even push it even further to the most vulnerable of the vulnerable, which is kind of the elder refugees. So we're going to go over clinical and educational program for the underserved, basically addressing this issue of elder well-being, elder brain health, as well as other psychiatric issues that could happen. So where to start, really? I am a clinician. All of my research has centered around clinical care. And I, through my career, you'd start as a clinician, and then maybe through the promotional track, then you move around those domains to basically then be called a clinician educator. And I think it is helpful for people to really know where they are at and what they are doing. But I think it's also kind of, if you are a clinician and you also, your heart is there for the teaching, this is who I could define myself as. So who was my audience throughout those years? So you will see through the programs, I will show you both kind of here, but also nationally and also internationally. My audience has been health professionals, of course, in programs like fellowships and residency programs and writing curricula for them. Paraprofessionals, which would make a lot of sense when you start working internationally, because people cannot really afford to go to medical schools for 7-8 years and then for training and then be able kind of not to pay for medical school to start with, but also they want to start earning money and be able to live. And then the general public, whether this is increasing awareness, doing public health campaigns, but also through the COVID-19 pandemic, basically explaining a lot about the post-acute COVID syndrome, whether it is through the news and newspapers and radio shows and that type of stuff. So when your audience is that broad, and then when you are doing a lot of kind of international work, really the world becomes your playground. And it is very good to see it that way, because it is less defensive than you thinking, oh my God, I'm going into a territory that I don't know much about. But actually, if you go there to explore, learn, do it in also with fun, and then with the local people, then you could do a lot of stuff. So why really care? Why care to go do all of these things, whether it's abroad or within communities in America? It's because this is what I do for a living, right? So I am a neuropsychiatrist, and neuropsychiatry accounts for 30% of the world non-communicable diseases, which are becoming really the threat and the most important diseases that are increasing, exploding actually exponentially everywhere in the world, rather than the communicable diseases that we used to kind of focus on, or like infections, or on mother and child, with children being less than 5 years old. And with this, basically, just if you think about stroke, migraine, epilepsy, dementia, depression, traumatic brain injury, schizophrenia, they actually, the burden to the their contribution to the global burden of disease is huge. This is where a lot of economics and really lack of, for the better or the worse, like quality of life goes into. So we really need to address those things and work through them. As a neuropsychiatrist, you don't make a divide between stroke and depression, right? It is one entity with people that are stroking and being depressed at the same time, for example. So And so from there, I also learned through years of clinical work, whether it is here at home in Boston and or everywhere else, that one size does not fit all. Actually, you saw Dr. Chu saying earlier with a question mark, would one size fit all? I could definitely say that it does not. However, we are not really talking much about it yet. We're starting just about to acknowledge that cultural norms might be different for different people. We're starting the dialogue about race. We're starting to talk about how much older adults are actually stigmatized through ageism. We're starting to talk about gender and discrimination, perhaps about lack of education, about poverty, how religion and spirituality fit into all of that. So we need to not only just start to acknowledge, but really see those diseases through that lens, because that will make a big difference. So I'll start you in Lebanon, and this is a very big AD campaign that I have done a few years ago with the Ministry of Social Affairs in Lebanon, that was targeted towards preserving autonomy. And why is that? Because actually I was targeting the AD campaign that we also did with the Alzheimer's Disease International, targeting the community, the caregivers, the people, rather than the professionals. So see how kind of you are going in for an educational program, but then your goals become a bit different than if you are just doing the same way and then your audience are the doctors or the nurses there. So what we did is we trained caregivers and the community through municipalities, through social workers that actually were working in those municipalities. We mapped the whole country and we targeted people within clusters, whether they are in the north of Lebanon or whether they are in Mount Lebanon, in Beirut, or in the south. And we went to them and tried to explain that, hey, if you start really noticing that your loved one is not joining your mealtime, and if at mealtime they are not engaging with you, or if you are feeding them, and if they are having trouble with bathing and not taking their medication, you need to let us know, because that might be a bit more than something you could handle. There could be a disease, a disorder there that we could help with, and help you basically understand what Alzheimer's disease means, what Alzheimer's disease and with depression means, and how you as a caregiver, you could help the person that is sick, but also help yourself. And actually it was a great, I think, campaign. So that was the numbers you see there are the first targeted, but then it enlarged. Actually, it was like almost like a drop of oil, that we started with that group, and that group became larger and larger and larger to cover every interested person and caregiver in the country. And if you know well about the region there, it's a region with a lot of wars and really like crises. So we just move from one crisis to the other rather than just have even any respite in between. So in 2011, started the Syrian war, and then Lebanon started having the influx of a lot of Syrian refugees. And so I went there between 2014 and 2017, almost in country, to basically address the needs of those refugees. And we've done that at multiple levels. But today I'm just going to really talk about the elder Syrian refugees in Lebanese camps, rather than all what we have done for the refugees there. And where we were trying basically to understand where they are coming from, what they needed, what they are still lacking. But got to realize that even though UNHCR maybe have offered some resources, those elders were mostly like preoccupied constantly with the fact that if they die in exile, where would they be buried? Or that if now they are there in Lebanon, but what happens to if they have left back home some family members? And there was no way to basically be able to reach them where they are at unless you discuss those issues. I mean, I had no way of knowing that what consumed them was that they were thinking, what if they've died in exile? Of course, UNHCR actually in Lebanon and other places of the world would cover urgent stuff. So if they needed surgery, or for women, if they needed to like give childbirth, but they don't cover all the medication, for example, for the non-communicable diseases. So those people, blood pressure was through the roof. Their diabetes was like completely not under control. And then you had to engage with them one way or the other to get them back to follow a certain routine, to take care of themselves, to take care of brain health, and try to test them. And then when you test them, actually, this is what is in your face, is that they're very, very depressed because this is what is preoccupying them. And of course, their cognitive testing is going to not be good because they are so depressed. And at the same time, you have this level of lack of education among the refugees. And so what do you do with that? You target mostly the depression to get everything else better, and to get brain health targeted as well. So moving from Lebanon to Jimma, Ethiopia, actually is another level where now my audience is not the general public per se, is not kind of caregivers, but is mid-level professionals. And this is where I was telling you that those are people that cannot afford to go through 7 years of medical school and then go, for example, into psychiatry or neurology residency, right? But the need is huge in Ethiopia. This is a huge country with more than 80 million people. I mean, now, unfortunately, at war as well in the Tigris region. Beautiful country. They are dispersed, so they have a very few psychiatrists, maybe around 14 or 15, that they have them go through a residency program like here. But you can't have 14 or even 20 psychiatrists for a country of more than 80 million people. So what we did is we went into a rural area. So Jimma is southwest of Addis Ababa. So that was already a statement that we are not training people from within a huge urban center. So in Jimma, we got everybody who is interested in this, who would have done 1 year of any college education. It could be in any domain that they want, that they would come, and then we would train them as having a master's in mental health. And those people then later on will be everywhere in the country and attending to mental health, which this is exactly what happened. We started in 2008 with 4 master's students, and now we are over 100. And they are everywhere. So they're not only in Addis, they are everywhere in Ethiopia. They're very well trained on community psychiatry and on community brain health. By the way, in Ethiopia, if you are doing community psychiatry, you see a lot of traumatic brain injury, you see a lot of intellectual disability, you see a lot of epilepsy as well. You're seeing them to treat them actually. And this is one, so Farah Adisu is one of the masters, like the first group that we were involved together in trying to find the predictors of length of stay in the hospital. And I am very proud of her. And this is one of the articles that actually for now has been cited all over about that. And as you understand, they don't have enough supply of psychotropics. There is a wide range of psychosocial interventions that one can do with them that they were not doing. And with few beds and you have a length of stay, people literally were staying under trees on the campus of Jimma University. So moving from there, so again, your audience here are mid-level professionals, to a country that is very close to Ethiopia, which is Somaliland. And I want to say that actually it is a self-proclaimed country. So they don't have independence yet, but there are some other countries like the UK that give them that special status. But Somaliland is one of those places in the world that is like beyond poverty level, really like very, very poor people. And they have a university in Hargeisa, which is the University of Hargeisa, that was starting kind of to think about, okay, beyond internal medicine, who can we catch by trying to train people in them, in those specialties. And then they thought that there is a major problem with mental health as well as with brain health and neurology, with very severe sickness. I mean, whether it is on schizophrenic patients and agitated patients being chained at home, to patients basically with meningoencephalitis or a very bad tetanus that you cannot treat, because even if you treat them and bring them to the hospital, there is no hospital beds that are enough, and there is no ICU, there is no ventilators there. So that was a major thing. And we took on this challenge to start a dual residency program in neurology and psychiatry. And from the first trip there around the 2010, 2012, to basically graduating 3 wonderful residents now in dual residency that are psychiatrists and neurologists, it was really a big thing, because I mean, I could say it now that this was done, but through those, like, I would say 7 to 9 years until it came to fruition. And this is what has happened. So many things have happened in between. We had to change places of where those residents could train. There was an uprising and almost civil war as in part of Ethiopia, because we were, again, remember those other programs that we have done with paraprofessionals. We were trying to use our collaboration with those people there to basically give them the psychiatry training that they need, because there is nobody in Somaliland for that. But we had to move them very quickly from there to basically Addis to train in Emmanuel Hospital and in Black Lion. And then even with that, work with them about their security and whether they felt safe staying outside of their country in a place where Somalis were now targeted by a certain actually population group in Ethiopia. So it takes a lot, because you're not only just dealing with starting a curricula, building the curricula, getting them to see enough cases, training them on cases, supervising with them. You are doing all of that in a very tumultuous actually environment and moving with it to basically make it happen. And then after all of that, they went back to Hargeisa for their neurology training. And then the COVID-19 pandemic hit, which actually took the life, unfortunately, of the dean of the University of Hargeisa, who was at the forefront for pushing that program. And from there, again, back probably to caregivers. So because of the work I have done in Lebanon, then through the MGH connection with Uganda, MGH has a huge presence in Uganda, actually. We went there to work with their, at that point, there were, some of them were doctors, others were paraprofessionals, but across the board, people within the university in Uganda that were interested in dementia, but also caregivers that were interested in that. But the coalition was much bigger, and we, because we could not do any of that work without really talking to faith leaders and being able to move forward with that. So I did a lot of work with this group and with caregivers, and this is where kind of I gained a better understanding about the concept of vigilance and caregiving, rather than being a burden, as we always hear about it here. So the caregiver is there to help out, but to as much as possible keep the elder person doing what they could do and in connection with nature, because this is part of their spirituality, the way that they actually will thrive even with the disease, but at the same time feeling loved. Moving on to traumatic brain injury, right? I put that slide there is just mostly to explain to everybody you see some colors up there. It's because people track those things. But for most of the countries in the world where even traumatic brain injury is a huge problem, there is no tracking. So that's why there is no colors, right? However, we do know that the roads are in very bad shape, right? People are either pedestrian or on those mopeds on roads that are very bad, at times very, very narrow, and then they get hit by a truck, they are in collision, and then they have very severe traumatic brain injuries. There is a lot of violence in other parts of the world as well, and this is how people get traumatic brain injuries as well. And so we try to raise awareness on that traumatic brain injury and took kind of the whole of Middle East. And then with that work, actually, the Uganda Ministry of Health had asked us to do more work just targeting traumatic brain injury dementias in Uganda as well. So this is just to tell people that if you don't see it happening, it doesn't mean, I mean, when at times you look about worldwide stuff and you don't see anything in other countries, it doesn't mean that they don't have them. It's just underreported and nobody has worked through that really to address that. So it is always good to understand what's going on in the places you are working in. And so to get back to the Anne Klibanski Visiting Scholar Program, it really actually gave me this, I would say, extension to be able to share this work both at Johns Hopkins and at the Biggs Institute in San Antonio to really put this shine that light that race, ethnicity, and culture are very important in our dementia experience. At the same time, I was actually editing a book with Dr. Stern on memory loss and dementia, mostly targeting. So even though I was giving those talks to professionals already, the book was targeting the community and the caregivers and people that want to know more about that. So sometimes those programs are going to intersect for you to be able to do right what you're very passionate about. And so from that, if I may say, tour within the Anne Klibanski Scholar Award is really, one might ask themselves, why should we look into race and culture? Because it actually impregnates everything. And you've heard in the first part of the lecture that, I mean, you have to go where people are. We have to know that if we're giving people the diagnoses, it is the right diagnosis for them because it is the norm in this culture. And after we make a diagnosis, we need to treat them right, because most of them, like, even if you make the diagnosis, they're not treated compared to their counterpart that are white, for example. The resources should be there. And maybe actually their whole thinking of caregiving is different than a white female caregiver. So all of those things are very important. And to top it all, I am sure that all of you on this call, at least, or on this talk, know about the big FDA, push for the aducanumab as a treatment for depression, for Alzheimer's disease. The problem, though, is beyond the debate whether it is good or not for Alzheimer's disease, beyond the debate that it did not do anything for cognition, it is actually a very unequitable treatment, right? Because to be able to qualify for it, you have to have access to a PET scan. If you don't have access to a PET scan, forget about it. If you receive it, you will need multiple MRIs to really see if there is also some benefit to it. If you don't have access to that, forget about it. And then the cost of it is like huge if you are not within a certain like insurance system or in a certain culture. needless to say, the whole world may not be able to get it, even if they want to. And even, again, away from the debate whether this is good medicine or not good medicine, but this is again pushing that also in the trials for aducanumab, there wasn't a full kind of diversity either. So this is very problematic because it impacts our everyday life every single time we're doing it. Moving forward to the pandemic in the last few minutes. So we tried basically to understand not only the dementia, but how the COVID-19 actually affected our older minority population, from how they came across the disease, how badly that disease basically impacted them, and they went to ICUs. And yet, in our post-acute COVID syndrome clinic, we don't see the patients that were the most impacted by it, which were the older patients from basically either Latinx or African American background. And we still have so much to do to really break those barriers and get people to the care they need, and not continue on really just giving care to people that are educated, that know how to access our clinics and show up, from just either having the disease, the post-acute, being diagnosed with COVID, they stayed in their home. Often, most of them were never hospitalized. So, and again, you have to look for those things. They're not going to be there just for you to see, because already the hospital has a certain catchment area. So we have to really push towards making things equitable, putting that lens of the race and people that are very vulnerable and not served. So those are my references. I mean, if you guys want to dig deeper into that. And with that, I thank you very much for listening to what we had to talk, and we'll open it up for the questions. Thank you so much.
Great. Thank you so much. This was just such a wealth of information and such an important topic. I will start with a few questions, and then I'll see while we wait for maybe some others to pop in. But Dr. Joo, I'm really interested in this concept of peers and, how to work. So I work with individuals with bipolar disorder. So I work with individuals that have chronic, serious mental health conditions, and we're always trying to sort of understand how we can work with peer specialists depending on kind of where they're at and meeting them where they're at. So I wanted to get your thoughts on how you do that. If you have regular check-ins with them, is there some sort of self-assessment monitoring thing that you do? How do you kind of keep track on your peer specialists, make sure they're sort of in a place to do the work, if you will? Yeah.
So I think when you're using, well, at least my approach to recruiting peer specialists or peer mentors for my study has been just trying to choose the best and the most motivated and so we have a very kind of pretty good support in place with a social worker who checks in on them every week. So I don't necessarily think of it as kind of checking in on them, but she's providing supervision to make sure that the work that they're doing is kind of in line with the, what was intended, like the fidelity of the intervention. So part of supervising them is trying to figure out if what they're doing is consistent, but it's also checking in with them to see how they're doing. But my approach has been to make sure that they are pretty symptom-free so that they're not struggling, because I think it is quite difficult to be able to, put yourself totally into a job if you are struggling to a great degree.
Yeah, that's been a challenge for us. But Dr. Chemali, there's a question for you in the chat about, did I see cell phone use as a risk? Can you comment on how it is a risk?
So it is a risk for pedestrian, and so in the areas that we studied in the Middle East, actually, which span multiple countries, if you are a pedestrian and perhaps a male pedestrian and you're using your phone you are more at risk to have an accident and then hence have a traumatic brain injury. And the same thing also is for drivers that actually were also on their phone.
Interesting. And then just another question, Dr. Chu, about the stepped care model that you mentioned. I was really curious. You mentioned sort of maybe peer specialists being sort of the first step in a stepped care model, and how you would sort of determine, sort of match with peer specialists, how you sort of determine that the patient is sort of in a place to do peer specialists, or is there some sort of comprehensive assessment you do before that? How do you sort of start with peer specialists, I guess?
Yeah, start meaning, was your question about matching?
Yeah, you sort of mentioned that peer specialists could be sort of the first step, if you will, on a stepped care approach. I was just sort of curious how you would sort of begin with peer specialists. Maybe I'm misunderstanding.
So I'm thinking something like the intervention that I'm testing right now, that they provide psychosocial support. That's not rigorous psychotherapy, but recruiting them and training them to provide kind of psychosocial support as well as kind of goal-oriented meetings could be really helpful and has some bearing on reducing depression. But if the depression, let's say, if they don't fall below a threshold, let's say PHQ of 10 or PHQ 10 of 5, you measure it to see where their depressive symptoms are. And if it doesn't go below a certain threshold, and they've already had, let's say, 8 or 10 weeks of peer support, then they would move on to the professional who could provide professional psychotherapy. So that was what I was thinking about in terms of stepped approach.
Right, in the remaining minute or two, I know Dr. Chemali, Dr. Chu, you have questions for each other. I want to make sure you guys have an opportunity to ask as well.
I was just curious, it seems like Dr. Chemali has been in the Middle East in various areas, Lebanon, as well as other places. And I wonder if locally, the ideas of dementia and cognitive impairment and its relation to aging, how much variation there is, or is there a great deal of commonality?
So there is, as you might expect, there is a huge variation depending on the group you are working with. There is a variation whether you are seeing those patients at MGH or in Salem already. It's not even maybe 15 miles away. And if you go even further to another kind of sister hospital, but really community, like in Cooley Dickinson, it's a totally different thing. So it's a huge variation. Unfortunately, the system still sees it as in kind of one denominator, one commonality, and pushes towards that. But this is where kind of a lot of education with the caregivers, with the primary care physicians, and the fellows, the resident, is basically to take kind of the patient as one person at a time and just move with that.
Yeah.
Great. Well, unfortunately, I do see we're at the hour here. So again, I just want to thank you both for your talks today and for collaborating and working together on this lecture series. And again, we look forward to seeing your work in this important space continue to grow. Thank you so much for your time.
Thank you for having me.
Thank you very much. Bye.
Bye.